मनजिंदर का ही वो कृपा है जो 1 आवर इस क्लास के बहाने विटामिन डी मिल जाता है धूप में बैठ के।
इसको ना दोपहर को कर लो और ज्यादा विटामिन डी बन जाएगा।
We are live, sir.
हाँ हाँ, डॉक्टर मनिंदर काइंडली ओपन।
Good morning. I welcome all the delegates and respected faculties. I request Dr. Meena, Secretary IP Delhi, to start the proceedings.
Hello, good morning to all. On behalf of Indian Academic Pediatrics, very welcome to all participant delegates and our faculties and chairpersons. Warm welcome to our today's speaker, Dr. VEENA Raghunathan, the very dynamic and very knowledgeable speaker. And welcome to our chairperson, Lakshmi ma'am and Madhu ma'am. I think Madhu ma'am is still not joined. And thanks to Maninder for design such a beautiful program. Over to President. Dr. Ajay Bose.
Yeah, good morning. It's nice Sunday morning, clear skies. And today we have basic ventilation. So I request Dr. Maninder Dhaliwal to please introduce the speakers and the chairpersons.
Good morning, everybody. Thank you, Ajay sir. Thank you, Dr. Meena. Thank you, Dinesh sir, for giving us a chance. And this module has been basically for like a priming module, a bridging course for the updates and the latest that are happening in PICU. So we have done the intubation, we have done oxygen delivery devices, we have done the approach to a sick child, and now we are going ahead with the ventilation. So what are the various modes? What are the alarms? How do you want to choose a mode? What all we have to do? So we have great experts with us. So the moderator for the session would be Dr. Lakshmi. She is a good friend. She is a philosopher, and she's the most dynamic pediatric intensivist in Western India. She is leading the PICU at Wadia's Children's Hospital, one of the biggest PICUs in Western India. And she has many students of hers, and they have won many gold medals in PICU fellowship. So we have a very great teacher with us, Dr. Lakshmi. It's a pleasure to have you here with us. And then
Thank you.
And then we have the speaker for today, Dr. VEENA Raghunathan. She is a colleague. She is at Amrita Hospital. She has got many degrees to her, from MD, FNB, then again DNB, then ED course. So a lot of knowledge is incorporated into her, and now she's running practicing with me at Amrita Hospital. So over to Dr. VEENA Raghunathan to please start the course and hit on the basics.
Thank you, Dr. Maninder. I think this is one of the few times you've actually introduced me somewhere in a formal way. Anyway, so we are going to be beginning with the basics of invasive ventilation. And first and foremost, congratulations to Delhi IIP team for this wonderful course. We'll start with...
You have to go for slideshow.
Oh, sorry, 1 second. Is it okay now?
Yes.
Okay. Right. So we all know why we go in for invasive ventilation. Basically, when there is severe respiratory distress, respiratory failure to respond to NIV, or inability to protect the airway. So indications are quite clear-cut. But then once we decide to ventilate, then which is the mode we should choose? What exactly is a ventilator mode? And pressure versus volume. Is there any difference, advantage? So these are the broad things that we're going to cover today. So we say that life was much better previously. That also applies to ventilation. So when we started off, and the first book was there of ventilatory modes, it described only 3 modes: assist, control, and assist control. Life was simple. But now with all the advancements, we have many modes, many names. Sometimes there are names that we're not very familiar with, and it's all very confusing. But as we say in life, same applies to ventilation, that if your basics are right, then probably you'll be able to understand and use all modes too. So let's start from the beginning. what is a mode of ventilation? So mode is basically a predetermined pattern of interaction between the ventilator and the patient. So when we describe a mode, we need to describe a few important things for a complete description. So it needs to be the control variable, phase variable, breath sequence, and breath type. So we'll be discussing each of these one by one. So what do we mean by control variable? Control variable is the primary variable that we are setting to control. So for example, we can set a pressure control. Means we are going to set the pressure that we want the ventilator to deliver. Similarly, volume control. So this is something which is going to be constant because that's what we have set. So it's an independent variable. So now this graph is showing you the differences between pressure and volume control. So if we see on the left side, we have a decelerating flow pattern. Okay, on the left side, we have a constant flow pattern, which is basically a volume control ventilation. Here, when the flow is going to go constantly inside during the inspiration, the pressure will slowly build up. As against pressure control, where the flow is going to be a decelerating flow, and then the pressure rise is going to be high right in the beginning of inspiration. So we describe this as a shark fin pattern in volume ventilation and a square wave pattern in pressure ventilation. The primary difference being that volume ventilation has a constant flow and pressure ventilation has a decelerating flow. Now we come to what is called as conditional variables. So these are the variables which are changing with every breath. So it depends on the set control variable. So for example, if I set volume, then the pressure is the conditional variable because that is going to change depending on the lung characteristics. So if the lung is a very compliant lung, the pressure will be low. If the compliance of the lung is bad, then the pressure is going to be high. So let's look at this graph. This is, if you can make out from the flow, this is a volume ventilation, volume control ventilation, because it's a constant flow. So if you can see that when the lung compliance decreases, then the pressure is going higher, whereas the volume is going to be the same, constant, because that's what we've set. So volume is set and constant and pressure has changed. And here it's the opposite because this is pressure control ventilation. And here we have set the pressure. So when the lung compliance decreases, the pressure is going to remain the same, but so the volume is going to get compromised and it's going to be lower. Now we'll move on to what we call as a phase variables. So the phase variables are the variables which are used to measure, which are measured by the ventilator to initiate some phase of the breath cycle. So we have a trigger variable, which is the reason why the breath begins. Then we have something called the limit variable, which is limiting the magnitude of any parameter. It may be pressure, it may be volume during the inspiration. And we have something called as a cycle variable, which is telling us what is causing the inspiration to end. So if we look at this graph, on the left, we have what is a time-triggered breath, which means we've set an I time, and at the start of the breath cycle, the breath is getting delivered. The flow is going into the patient. The second one, the middle, is a flow triggered, which means that the patient is generating some flow. It's drawing in some flow, and then the breath is getting delivered. This is a flow triggered. And the third is the pressure triggered, which means that there is a baseline pressure going on in the ventilator. When that pressure drops to some amount, then the breath is getting triggered. So these are the trigger variables. The second is the limit variable. Limit variable is the maximum value of a variable, which can be pressure, volume, or flow, which is attained during the inspiration. So what we need to remember is limit is something that is going to be at that level during the inspiration. It's not going to rise above that level. For example, if it's a pressure limited breath, which we set at 30, then the pressure delivered is going to be 30 during inspiration, but it is not going to exceed 30. But this is going to continue throughout the inspiratory phase. It does not cause the inspiration to cycle over to expiration. So this is what we need to remember, that a limit variable is the limit during inspiration. It is not a reason why the breath is cycled to expiration, because that is something different. That is the cycle variable. So here again, this graph is showing how the pressure limit is there in the first graph A. So the pressure is limited to that level during inspiration, and then cycle variable decides the change to expiration. Similarly, flow limited and volume limited. So there is something we need to know, that there is a maximum safety pressure which is available, especially in the volume control modes. So basically, pressure limit is something that is going to be maintained during the inspiration, but we also set a P max, which means that if the pressure exceeds that at any time during the breath cycle, then the ventilator is going to cycle it from inspiration to expiration. So that's the difference between pressure limit and pressure cycling. So coming to this cycling, the cycling is the variable which is going to decide when the inspiration has ended and when the expiration is going to start. So as I told you, cycle variable can be a pressure when we set the high pressure alarm in the ventilator. So if the pressure reaches 35, then no matter what time has passed, the breath is going to be cycled to expiration. It can also be a flow cycle, which is used in pressure support ventilation, where when the flow drops to some percentage of the peak flow, then the breath is cycled to expiration. Or it can also be a time cycled respiration. So this is showing you the differences. So time cycle, we set the time, and at the end of that time, the breath is getting cycled to expiration. Whereas this is a volume cycle. So when the volume is achieved, it's getting cycled into expiration. And here, this is the pressure support, where there is a peak flow, and when the flow reaches some percentage of this peak flow, then it is cycled into expiration. The last variable in this phase variable is the baseline, which is the variable that is controlled in expiratory phase. So we should remember that expiratory phase, no matter what mode you use, is usually the same because it's a passive phase. Most commonly, pressure is controlled during the expiratory phase, which is what we apply as the PWP. So just coming to what we've discussed so far, we've discussed that every ventilator, when we set a control variable, which can be pressure, volume, mainly. And then there are some phase variables which decide how the inspiration is starting, how it's getting limited, and how it is going to cycle. So there is the trigger, cycle, baseline, and limit variables. Now coming to the breath type. So broadly, there are two types of breaths. One is the mandatory breath and one is the spontaneous breath. So what do we mean by mandatory breath? In mandatory breath, everything is done by the ventilator, which means the type of breath, the amount of volume or pressure which is given, and the cycling which happens, everything is decided by the ventilator. As against a spontaneous breath, where the patient is triggering and the patient is cycling the breath. So mandatory breath is a machine-driven breath, and also the assisted breath. In assisted breath and mandatory breath, what is the difference? Mandatory breath, the trigger, limit, cycle is all by the ventilator. In assisted breath, the trigger is by the patient, but after that, the breath delivered is completely taken over by the ventilator. So the limit and the cycling happens by the ventilator. Whereas in a supported breath, the trigger and cycling are by the patient, but the limit is by the ventilator. Example, pressure support. If we set a pressure support of 10, so the patient triggers the breath, that time the ventilator knows the patient has triggered, and it gives a pressure of 10, which is the limit during the inspiration. And then the cycling happens depending on the flow of the patient. So cycling and trigger is by the patient, but the limit is by the ventilator. And in completely spontaneous breath, trigger, limit, and cycle is all by the patient. So for example, in CPAP mode, it is an example of a totally spontaneous mode. So again, just to describe the different breaths, the first on the left side is a spontaneous breath, where the patient has triggered it, the pressure is dropped, and then we can see that everything is done by the patient here. There is no contribution of the ventilator. In a supported breath, the patient is triggering and the ventilator gives the limit of the
वॉल्यूम
pressure.
कम हो जाता है पता नहीं क्यों.
Am I not audible?
You're audible.
Yes. Okay. So in a supported breath, the patient triggers and then the pressure is given by the ventilator as per the limit set and the flow cycling happens as per the patient's breath flow. So this is a supported breath. In assisted, as I told you, the patient just has to trigger the breath, but limit and cycling is by the ventilator. And in mandatory breath, everything, TLC, trigger, limit and cycle is all by the ventilator. Now we come to the breath sequence. So we finished control variable. We finished the pressure control difference. We have finished the phase variables. We have finished the breath type. Now we come to breath sequence. So in a continuous spontaneous ventilation, that means all the breaths are going to be spontaneous only. Spontaneous breaths are possible and then there are some intermittent mandatory breaths. Both are allowed. This becomes an intermittent mandatory ventilation. When there are no spontaneous breaths possible and it's all mandatory breaths, we call this as the continuous mandatory ventilation. So this is what we call as the breath sequence. So basically, when we say that this is a pressure control mode of ventilation, or we say volume control mode of ventilation, it is a wrong terminology. Pressure and volume are control variables. They are not the modes. They just tell us which is the constant variable that we have set. So in order to correctly describe a ventilatory mode, we must jointly state the control variable as well as the respiratory sequence. So we can say it's a volume control mandatory ventilation, or pressure control mandatory ventilation, volume control, synchronized intermittent mandatory ventilation. So this is the correct way to describe the modes. Coming to targeting scheme. So basically a targeting scheme is something which the ventilator uses depending on the input it gets, and then it delivers a particular output. So the various modes work on various targeting schemes. There are 7 described schemes which are described in terms of the feedback, control, and the loops. So for example, our pressure control CMV mode is going to be a set point where we are setting the pressure control, and ventilator, no matter what, is going to deliver that pressure. Now we also have PRVC, which many of us use, which is an adaptive type of targeting sequence in which the ventilator automatically sets a target between the breaths and it can respond to the varying patient condition. So this is just for you to know that there are various types of targeting sequences, and it's a good idea to also know about the targeting sequence because that is when you'll understand the physics of the ventilation. So there are only 2 categories of breaths, spontaneous or mandatory. There are only 3 breath sequences, which is control mandatory, intermittent mandatory, or continuous support ventilation. There are only 5 ventilatory patterns, 7 targeting schemes. So when we try to describe any ventilator mode or when we try to understand, we must try to categorize it in all of this. That will give us a good understanding of what we are using on our patient. So for example, if you see here, see how they've described each of the modes. So for example, if we take volume control SIMV. So it's a volume control variable, intermittent mandatory ventilation, which is the breath sequence, and the set point targeting sequence. So that's how we should describe the ventilatory modes. Now let's come to pressure control versus volume control. I already told you that the difference here in these two is based on the flows, which are different. In pressure control, we have a decelerating flow pattern, whereas in a volume control, there is a constant flow pattern. So in pressure control, our pressure level is guaranteed, but the tidal volume can change and will change if the lung mechanics are variable. In volume control, the tidal volume is guaranteed, even if the airway pressure fluctuates. So if the lung mechanics become poor, the airway pressures will rise, and sometimes they can rise to unacceptable levels. So a little bit more about pressure control. So we feel that when we use pressure control, our airway pressures are under our control. But this is actually a false sense of security because we are actually just seeing the airway pressure and not the transpulmonary pressure. And we know that the lung is a heterogeneous lung. So you can still cause barotrauma, although you have the airway pressure under your control. But there are some advantages that because of the decelerating flow, the alveoli get filled very quickly. So it has a faster tidal volume delivery, and it has better adaptation if a patient is having flow hunger, or if a patient is having an increased inspiratory effort, because he's going to get the flow quickly. And there is also a favorable gas distribution. Like, for example, if you drop a glass of water on the floor, the water is just going to go everywhere. So pressure control ventilation is somewhat similar to that it is able to reach every nook and corner of the lung. And it is also a good mode to use if there is a leak in the system. So although volume is not lost, you are able to sort of give the correct pressure that you want to, and it doesn't change due to the leak that happens. What about an ARDS? Is pressure control a better mode, or is volume control a better mode? So we have got lots of studies which are being done from many, many decades. So we have failed to demonstrate any mortality benefit. So pressure control, some studies have shown they have better oxygenation. We are able to safely give the ventilatory settings as per we want. pH levels are better, decrease in multi-organ failure, but no effect on mortality. Even a recent RCT again says that if you use pressure control, the need for sedation and adjunctive therapies reduces, but again, there is no effect on the mortality. So there are some disadvantages of pressure control. As I told you, that if there is unstable or changing lung mechanics, then it will directly affect the tidal volumes. For example, if the ET gets blocked and you are giving a pressure control, then the pressure is going to go in, but the volume delivery is not going to happen. And sometimes the high peak inspiratory flow may aggravate the lung injury because of generating shear forces, which is lower in the volume control because the peak inspiratory flow and volume control is lower. So volume control is a constant flow, and in this we are guaranteeing the tidal volume. Since we set the tidal volume and the rate, the minute ventilation also is guaranteed. And in volume control, we sometimes apply the inspiratory pause. I will tell you about the inspiratory pause. When we apply the inspiratory pause, it helps to improve the tidal volume distribution. It helps to make the VQ ratio better, and it also has a pendulum effect. So if we look at this graph, so we can see the green is basically the flow, which is constant. And at the end of inspiration, we are applying a inspiratory pause. So the pressure required to deliver the inspiratory breath is higher than the pressure which is maintained in the system when the pause is applied. So the highest pressure which is given during the inspiration is the P peak, whereas when we apply the pause, the pressure reduces and comes to a level called the P flat. And just a bit about pendulum effect. So we know that there is heterogeneous alveoli. One alveoli may be more compliant and the other may be more collapsed. So when we apply this pause, there is some exchange of gas between the lung units, and this is helping to make the lung a bit more expanded and improve the VQ match. So volume control, most of the studies, if we see, especially the older ones, they've all used volume control for ARDS. Although we say pressure has its advantages, so really at the end of the day, you use the mode which you are comfortable with. We can't really say pressure is better or volume is better. But yeah, for the aerosol delivery, nebulization, because of the constant flow pattern, volume control has some advantage. There are disadvantages too. Because of the fixed inspiratory flow, if a patient becomes active or needs a higher inspiratory flow, this cannot meet that demand. And that can sometimes lead to dysynchrony or double triggering effect, which means the breath is delivered, but patient is still wanting flow. And therefore, there is another breath which comes onto this, which is called as the breath stacking effect. So again, just a bit about the inspiratory hold. So here we see that the pressure is right. We always have this analogy where we compare it to the inflation of a balloon. So right at the start, when we start blowing into a balloon, there is just an increase in pressure and the balloon doesn't start getting inflated. This is to overcome the resistance of the airway right till we reach up to the lung. Thereafter, as we start giving more pressure, the balloon is inflating till the point we reach the PIP. After that, when we close the balloon, that's when the pressure inside slightly reduces. That's when we apply the inspiratory pause. And there we get what is called as the P plateau. So P plateau is the pressure that is required to keep the lung open. And therefore, when there is a difference between the PIP and the P plat, which is higher, it means that the resistance of the system is higher. Whereas if both the PIP and P plat are high, and the difference between them is the same, that means that the lung compliance has reduced. So basically, we need to look at this, the difference between the P peak and the P plat, which will give us an idea of the resistance of the system. And in both asthma, ARDS, lung physiology, we target the P plats. In asthma, again, there is no consensus as to which mode is better. So volume control, many prefer because of the constant flow pattern. It's supposed to be better, but pressure control also some prefer because it can limit your peak airway pressure and it is more effective in overcoming the high resistance. Coming to SIMV-PS, I saw in the group that most are going for the SIMV-PS mode for ventilating a patient. So do we really know how many type of breaths are there in SIMV-PS? There are 3 types of breaths. First is the control mandatory breath. So basically in SIMV, what do? We set a rate and we set a tidal volume. So these are basically for the mandatory breaths. So if we see in this graph, the first breath which is getting delivered is a constant flow mandatory breath. Now, if the patient triggers during the trigger window of the breath, that time he gets what is called as a assisted synchronized breath. So this is the second type of breath which can happen in the SIMV. And then in between, if the patient is breathing, then he gets a pressure support which we have applied, which is the spontaneous breath. So if you carefully look, the constant flow are seen in the mandatory and the assisted breaths, whereas in the spontaneous breath, we are getting the decelerating flow because we are applying the pressure support. So from the patient point of view, sometimes he is getting a constant flow, sometimes he is getting a decelerating flow. So actually, it's not very comfortable for the patient. But probably for us as doctors, we feel that, okay, we've set a rate. So even if the patient sleeps or stops breathing, then he's at least going to get that much rate. And that's why we are probably more comfortable. But we should know that there are different types of breaths which are given in SIMV, which may probably be not the best for the patient point of view. Advantages of SIMV, we are guaranteeing the volume with the assisted and mandatory breaths. And basically, if we put a patient when we are weaning on an assist mode, then all the patient needs to do is trigger and then he gets a breath. So probably then the minute ventilation goes up in these patients and respiratory alkalosis is more. This is lesser in a SIMV-PS because you're giving a window for spontaneous breathing. And because of the active participation of the patient, there is less atrophy which occurs. So again, as I told you, SIMV, it's somewhat falling out of favor because of the different type of breaths which are delivered, which is not good for the patient. But it's still, if we probably survey, it will still be the most popular mode which is used by far in pediatrics. Coming to CPAP and PEEP, are they the same or are they different? So CPAP is the mode, and it is a mode in which it is allowing the spontaneous respiration to occur. So we are setting a particular baseline variable in this, that pressure is going to go on throughout the respiratory cycle, and the patient can breathe, trigger, limit, and cycle the breath in this on his own. PEEP is actually the baseline variable that we set, the value that we set. So usually it is set in conjunction with some other positive pressure ventilation like pressure support, assist control, or SIMV. So when we set a patient on pressure support, we tend to call it CPAP plus pressure support, but there's no need to. It's actually a pressure support ventilation because anyways you are giving some PEEP in this. That's part of the mode that you set. So there's no need to say pressure support plus PEEP or pressure support plus CPAP. It's enough to say pressure support. So in pressure support ventilation, what happens? the patient triggers the breath and then he gets the set pressure support, whatever we have set, 8, 10, whatever we set, that much pressure is delivered to the patient. And then when the the flow reduces to some percentage of the peak flow, then the breath is cycled to expiration. So it's a spontaneous triggering is there is flow cycling, but due to the lung characteristic or patient effort, the volume can change with every breath because it's controlled mainly by the patient. The problems we face is if a patient is on pressure support and goes into apnea, then he's not going to get any breaths. The volume delivery is variable. And if the resistance increases, there's secretions or there's some compliance problem, then again the volume delivery becomes a problem. Coming to PRVC, if we have time, I will, so PRVC, because this is again a mode that many of us use. So it works, as I told you, if you remember, on targeting adaptive ventilation. So it targets the inspiratory pressure. So we set a tidal volume, which it tries to deliver at the lowest possible airway pressure. And it uses a feedback method on a breath-to-breath basis. So with every breath, it is analyzing how much pressure is needed and it's going to adjust its pressure accordingly and give whatever volume we have set. And it's not a volume control mode because it is using decelerating flow. So although we say it's pressure regulated volume control, it's not a volume control mode. It is using a decelerating flow and it is analyzing breath to breath and giving the volume at the lowest possible pressure it can. So if we look at this, here we've put a patient on PRVC and he's breathing. This is the ventilator graphic, and then there is a drop in the compliance. So what happens? The ventilator realizes that, for that pressure, the volume that is being given is less. So we have set that volume. So it is going to try and give that volume in the next breath at the cost of pressure. So pressure might go up. So it can go up till with respect to whatever pressure limit we have set. So that is the PRVC mode. So it's giving flow in decelerating form. It's going to assure volume. But for any reason, if there is a drop in the compliance and the volume delivery gets compromised, it will increase the pressure in the next breath, subsequent breaths to deliver that volume, keeping in mind whatever pressure limit we have set. It will not exceed the pressure limit that we have set. So the advantage is it is using the decelerating flow pattern and the pressure automatically is adjusting for changes in the compliance. So we are ensuring the tidal volume delivery and at the same time we are limiting the pressures. Disadvantages is that the pressure delivered is dependent on the tidal volume which is achieved in the last pattern. So for example, we put a patient on PRVC and the patient is starting to have some air hunger and is going to take more breaths. So actually the ventilator will feel that the compliance is improved and it may actually end up giving lesser pressure in the next breath, which will cause more problems to the patient. So there can be some asynchrony with variable pressure. And again, when the patient effort keeps varying, then the ventilator may get confused and that can lead to asynchrony. And it is less suitable for patients with asthma. Again, it won't work if there is a gas leak. So if there is a significant leak, and if it is variable when you're doing bronchoscopy or any which ways, if there is a leak, then the volume cannot be delivered because the ventilator is going to judge the expiratory volume which it's getting back. And since the volume, it is going to try and increase the pressure every time, which is actually not what the patient requires. Limitation of PRVC. One more limitation is that basically it cannot distinguish between the improved compliance and the patient effort, what I told you before. So if the patient begins to generate higher flows, if he's anxious or pain or just needs more flow, the ventilator may misinterpret this effect and inappropriately decrease its output, thus increasing the patient's hunger and increasing the work of breathing for the patient. So pressure PRVC was breath to breath adaptive ventilation. There is something called a dual control within a breath. That is what is the volume assured pressure support. And in this basically, so you can see that volume in this basically it works like a pressure support. So, but it's just that in addition to that, we are setting a tidal volume. So if the tidal volume we have set is met, everything is given like a simple pressure support breath. But suppose the tidal volume we set is not met, then the ventilator within the same breath will change from the decelerating flow to the constant flow pattern and will continue the inspiration till we achieve our tidal volume. So the pressure limit is actually compromised, it's overridden, and the ventilator assures that the amount of volume we have set is delivered. And only after that happens, it switches over to the expiration. So this is the dual control within a breath. So that's about it. We know that there are various modes. I have covered only the basic ones, pressure control, because otherwise there's no end to this lecture. Basically, evidence is lacking even today as to which mode is better than the others. We need to understand the principles and the physics of the ventilation, because that will help us to understand whatever mode we are using. And at the end of the day, the message is use the mode that you are most familiar and most comfortable with. The only thing that we know after so many years of research is that probably that tidal volumes smaller are better than large tidal volumes. Apart from that, nothing really is shown any mortality benefit for us to say one is better than the other. Thank you very much.
Thank you. Thank you, Dr. VEENA. It was a very crisp and clear message. So I'll now ask some questions and ask the questions to moderator. There are some Q&A also. So this is to Dr. Lakshmi, I would ask. Can you see the screen?
Yeah, I can.
Okay, so the question was, many of them had told that which mode do you like to use? So the maximum answer that we got was basically SIMV PS. And then pressure, almost volume control was 0, and PRVC is gaining some traction. So what is your take on that, Dr. Lakshmi?
So like Veena said, we use the mode which we know the best. And for us, if we begin our ventilation in a sick child who we have sedated, paralyzed for the intubation, then at that time probably we use pressure control ventilation, because we've kind of knocked off all his drive at this time. Okay, so we begin with pressure control. And as the child gets better and we want to wean him, we start putting him on SIMV with pressure support. Now, SIMV as a beginning mode may not be the best mode to put the patient on, because his disease is still evolving, and if you've just sedated and paralyzed, the SIMV is actually not a SIMV anymore. It just gives the number of breaths that you have set. So that is how I look at it.
So I'll
And
divide this question further into two parts. Now,
okay.
At one point, you are saying that you use only pressure control and support and SIMV pressure mode in your unit. So,
We do use PRVC, but on and off, not as a beginning mode.
not as a beginning mode. So, but what about volume control? Do you not use volume control at all? Because this is the mode which was used in all ARDS studies to monitor the plateau pressure.
We also use volume control. It is not like we don't use it, but we use it less often. In my practice, what I see is we use it less often than the pressure control, which everybody ends up getting comfortable with. So that is how the unit policy works for us. Volume control we use more in bigger children, in children who are having neurological causes and not really so much of lung problems than
So in asthma, would you use a pressure control versus volume control? Which is your unit preference? Because when the pressure gets resolved, there will be sudden change in volume.
so asthma, I don't want to intubate.
You don't want to intubate. So message is clear. In asthma, we
Yeah.
really don't want to intubate. And if you're intubating, you need to be very
Yeah, I
clear.
haven't had to intubate an asthma for the last 5-6 years, so it's been a long time since we
Correct.
had
Now with
to.
HFNC and hyper, everything has changed a lot. Perfect. So Dr. VEENA, which mode do you use in your unit? The volume mode or the pressure mode?
So again, basically, it doesn't matter which mode we use. Personally, we use PRVC to initiate ventilation. But the thing is that we should know what we need to look at in the ventilator when we're using. So for example, pressure control we use, we need to look at the volumes and adjust our ventilator accordingly. Similarly, we use volume control, we need to look at the pressures. And SIMV-PS, which many seem to be using, is okay, but you need to know that there are different breaths that are getting delivered. So like for a pressure support breath, you need to look at the volumes that are specifically going in that time and then decide whether it's okay for your patient or not.
So you are saying basically that uh, uh, SIMV pressure support mode versus only pressure support mode as a weaning. Which one would you use, Dr. Lakshmi, in a acute weaning, not in a chronic weaning? In your unit, Dr. Lakshmi, you use SIMV pressure support, or you directly shift the patient from control mode to a pressure support and you extubate?
Okay. In that situation, when the patient has been on high sedation and you weaning off your sedation, we go on to SIMV for a short period of time till the patient is more awake. Once he is more awake, we put him on a CPAP pressure support just for a testing, like a spontaneous breathing trial, and then we devent the patient much sooner. So SIMV probably will be used for maybe 12 hours or something like that, till the patient is much awaker and more awake, and he's able to take all the breaths that he needs.
So somebody has asked a question, Dr. VEENA. In Mackay ventilator, the trigger factor goes from 0 to 10, actually, not 5, and the flow trigger. So the 0 means what and 10 means what in Mackay? I'll ask Dr. VEENA because we recently had a doubt regarding this.
Yeah, so Mackay ventilator, basically the flow that we set as a flow trigger, if we set it at 10, it means that this is a very sensitive trigger, which means that if the patient is going to just need a very little effort to trigger the breath, as against if we set a flow of 1 and 2, which means that the patient, that is a less sensitive trigger, which means the patient needs to do a much more effort to trigger the breath. So Mackay is a little different from the other ventilators with respect to the flow trigger which we set.
And Dr. Lakshmi, in your ventilators, in your unit, usually the flow triggers near 0 means they're very, very sensitive. In your unit, what are the ventilators that you have, just for my curiosity?
We do have a lot of Mackay, so
So
we are
you're familiar with it.
have a
Okay.
lot of Mackay, yeah.
Because they are different ventilators, different
Yeah.
flow triggers means
So
different.
when flow triggers, if you have, we have other ventilators also, Schiller and Bella Vista, these kind of ventilators. And in that, if you have to set a flow trigger, then you have the number there, 0.5 liters per minute, or you have 1 liter per minute or 2 liters per minute. So that is the flow the patient has to take, a negative of that, in order for the machine to realize that there is a breath that is needed by the patient. So that is where you have to see where the flow sensor is. Most of these machines have flow sensors right at the machine end and not at the patient end. So that also makes a difference as to how much time lag happens between when the patient needs the breath and when the machine gives the breath. There are some millisecond differences.
And then there's a question, like in asthma, do you paralyze the patient, Dr. Lakshmi, in the beginning? Or on what PEEP settings do you keep in the beginning and at the end?
So if I have to intubate and ventilate a patient of asthma, obviously I will have paralyzed the patient at the beginning. And what is the PEEP setting? PEEP setting, first of all, you will need a high PIP setting because you have to overcome the airway resistance. So setting a very conservative PIP settings doesn't help. And a PEEP setting, you can begin with a lower PEEP of 5 maybe or 4. There are recommendations for a ZEEP, that is a 0 PEEP, but I have never done a ZEEP. I have used inspiratory hold maneuvers to find out what is the auto PEEP and then use a moderate PEEP in the patient.
So in your unit, Dr. Lakshmi, with ARDS, which is severe, do you paralyze, sedate, and analgesia, all three, or do you do something different?
You do need everything, no? Sedation and analgesia are needed for any patient that you put on the tube. And paralysis, you may use at the beginning first, maybe 48 hours, and then you start decreasing the paralysis. You don't use it as like for 4 days or 5 days. We don't use it that much anymore.
Point taken. So start heavy, but then you have to wean fast. So you have already told you will intubate the patient of asthma late, and the body weight. So we don't use the actual body weight. I think so that message is also clear. We have taken up all the questions. There is
The body weight goes for both obese as well as underweight.
correct. So for obese, you will use the ideal body weight. For underweight, you can use the actual body weight. There's one more question is for a newborn, how much flow trigger is required to Dr. Lakshmi
For a newborn,
for neonate, right?
I don't do any neonate. So I'm going to pass the question. I don't do any NICU baby. So you just need a flow sensor at the proximal end. That's all I know.
So there are two flow sensors. So you need to have a flow sensor which has a proximal end, and the triggers now the ventilators are super smart. The trigger sensitivity as per percentage in MACA remains the same despite of newborn or adult. It remains the same. It's the percentage in MACA. In others, it's the flow per liter. So that doesn't matter. You can keep your trigger at 4 or 3. Then comes preferred setting for a young child of ARDS. Over to Dr. Lakshmi. What settings you would do in the beginning when you
So
are
if you
intubating a child?
have, okay, so let's assume that you have a child whose acute diagnosis is ARDS and you have put him on a mask, a full face mask, and you've been ventilating him, and you realize he's not getting any better, and you want to intubate and paralyze this patient. So you may be already on something around a 5 of PEEP and FiO2 of, let's say, 80 or 100 at the beginning. I have no idea what we are talking about, but 2 kilo, 2 years, 10 kilo is your common numbers. So you may start, you will keep your FiO2 at 100. Your pressure control, you may start with a PIP of 15 and a PEEP of maybe 8. And then you need to titrate your tidal volume once you get your numbers to get a 6 ml per kg kind of. So 60 ml ka tidal volume aane jitna, you have to adjust your PIP. After you start there, you have to make a start and then you titrate up and down. You keep your pressure limit at 30 and then you take it forward. I time, if you, it's a 2-year-old, so I time of 0.6, 0.7 would be more comfortable with a rate of 30.
So message is clear that you want to keep a plateau less than 30 and the tidal volume around 6 ml per kg and PEEP start with 8 and titrate PEEP according to driving pressures. You can keep the driving pressures around less than 16 if possible. And CO2s, what any cutoff that you follow, CO2s in your unit, Dr. Lakshmi? Permissive hypercapnia.
Yeah, so CO2 based on ABG, you can go on till you have a pH of 7.15. We've waited till a 7.1 also. And till that time, you tolerate your CO2. You
So
do
even a
not,
CO2 around 60, 65, 70, you tolerate it. You don't chase the CO2 in managing ARDS.
no, you
You
don't
chase the
dial
pH.
up the rates, you don't increase the tidal volume, you don't do any of those things.
Correct. And if there is a leak, how do you
You mean
manage
a lung
the,
leak or a peritubal leak?
I think so it's a peritubal leak we'll talk about, which has no cuff. Or it can be a lung leak also. How
If
much
it's a
pressure
huge
control is preferred?
peritubal leak, then you're not able to ventilate the patient. So if you're going to deal with ARDS, I would want the tube to have a cuff right at the beginning if you have a choice. And if you don't have a choice and you already have, it's very difficult. You look at whatever your inspiratory tidal volume, you will lose a lot of your air in your expiratory tidal volume. Lose some of it, but pressure loss hoga saath mein.
So would you shift the more to HFOV or you would like to continue in pressure control only?
You can try for some time and look at how the baby is breathing. Is the child settling? Give him 2 hours on that, whatever you're doing.
Somebody is asking a question if there's
God,
a
where
foreign
are they
body.
asking these questions? It's not seen on the, it's in the WhatsApp.
No, it's in the Q&A. So I'll ask the question they're asking is if the patient has inhaled the foreign body,
Oh,
so
now
what
it's foreign
settings
body
of
now.
ventilator do you use?
So usually a foreign body which has lodged into the right or left, you have to use something which has a low tidal volume. Don't use too much pressures because you will end up blowing up the normal lung. So it's okay to have similar to ARDS, so lower settings, but don't blow up the lung. You can use a little higher rates in this
Remove
situation.
the foreign body. That is the tip. Don't just keep him with you for the
Yeah, but
24
till
hours.
the time you get a scopy person in, you
Yeah.
will need to ventilate.
True, true. And then there's a question somebody is asking how to decide about I and E, I's to E ratio. Over to Dr. Veena. How do you decide on I to E ratio and what flow triggers you will keep in the beginning and at the end?
So I ratio, typically pediatric, we keep it 1:2. And depending on the pathology, if you're having an obstructive pathology, you want more time for expiration, you can increase it to 1:3, 1:4 also in asthma, bronchiolitis kind of settings. And on the other hand, in ARDS or a restrictive lung pattern, if we want to control our pressures, then sometimes we can go for the increasing of the I time. So we can make it smaller, go in for even a inverse ratio sometimes in extreme cases where, but typically starting would be 1:2 I ratio.
And the second question was pressure trigger or flow trigger.
So flow trigger has an advantage over pressure trigger because the patient's effort to trigger the breath is lesser. The minute the patient starts to trigger, then the flow trigger is achieved. As against for a pressure trigger, the patient would have to put in a more effort for the pressure difference to happen and the pressure trigger to get activated. So flow triggering would be better than pressure triggering.
Okay, so next question is for Dr. Lakshmi and then we'll close. The question is if the patient is already on CPAP for severe pneumonia and you want to change it to a invasive mode, which mode will you use? Pressure versus volume, SIMV versus control.
So the child is receiving CPAP via invasive mode or non-invasive mode?
NIV, CPAP.
Non-invasive. So he's
And then
on
you want to intubate.
non-invasive, and now I'm going to intubate. I can use PRVC at the beginning because you're saying that the child is having some worsening pneumonia. So he may have a lung compliance which is variable or which is worsening. So putting him on PRVC at the beginning is also an okay strategy. That was first question. What was the next question?
SIMV.
So SIMV early in the phase does not make sense. So keep him on controlled ventilation. Use PRVC with full control or keep him on pressure control ventilation with full control for the beginning. You have to do too many titrations. You may have to do a recruitment in this child if he's going into worsening ARDS. So no SIMV at the beginning.
So then one last question, then we'll close. When the CO2 is rising
Okay.
in ARDS,
Okay.
how do you deal with it?
So is there also hypoxemia that I'm dealing with, or it's just pure CO2?
I think so. They will be asking tough one, both.
Fine. So there is hypoxemia. One of the strategies is to prone the patient before we do anything else in ARDS. If you've done your PEEP titration or recruitment and you know what your optimal PEEP is, even then, if your patient is not better, you prone the patient. On proning, if you feel that you're not any better, then the next options left to you are HFOV only at this point. So we've done HFOV in prone. That hasn't stopped us from using HFOV. So that would be the thing which we could use, because in HFOV you can actually dissociate oxygenation control and carbon CO2 control. So you can do that.
Perfect, perfect. I think we'll close the session here. Beautiful answers given by the experts. And any comments from you, Dr. Lakshmi?
I think this is an amazing way of getting young doctors involved into intensive care. So kudos to Delhi IAP for doing this, and thank you, Maninder, for inviting me and putting me on the spot. Thank you, Veena, for that lovely presentation.
I now give the over to Dr. Dinesh, sir.
Yes. Thank you, everyone, and it's a wonderful. You can reach in academics and sessions. And thank you, Dr. Veena, such a wonderful basic ventilation scientific talk. And it is very, very helpful and encouraging to the youngsters. And sharing the experience of Dr. Lakshmi ma'am, such a wonderful answers. And the Dr. Maninder is bombarding lots of questions to ma'am. And that is actually the importance of these sessions. The discussion of the part. The discussion is more important. The learning should not be one way. Learning should be a both way. That is more important. And that is why this session is crafted with the help of Dr. Maninder and on the Delhi IAP platform. And our aim is that this learning should pass to the youngsters. In the residents working in the private hospitals, government setups, who are not much exposed to these cases also. But if they are exposed or suddenly in emergency they are having some cases, how to deal with these cases? That's more important for us. And right line treatments, right line protocol based treatments, so that key results are also good. I am seeing so many cases which are not dealt as per the protocols. That is why we are losing some cases also. So we can save our lives with the help of these protocols, with the help of these experiences of the Star Wars, and with this scientific learning. With this, thank you so much. And we are honored to have you, ma'am, on this platform. Thank you, Dr. Maninder. Thank you, Dr. Lakshmi, ma'am. Thank you, Dr. Veena. And thank you, the delegates. More important, our delegates, which is also very important because they are the main, you can say the main audience of this scientific session. Thank you so much.
Thank you.
Thank you, sir. Happy Diwali, everyone.